Well, hello there. We are pretty much done with the content on synovial joint. That's the information, but there's lecture 3 for chapter 9. That's what this one is. And we're going to go through some disorders and talk about some selected joints. But the selected joints part is not part of your exam. I think it's really just to gain appreciation for how crazy complicated joints are and to see, which joint do you think has the best, most stability. It's pretty interesting. So, all the books always talk about these same few joints. I don't know why they select these ones, but I don't know. So having said that, you have the joint between the mandible and the temporal bone here. So this is known as the temporomandibular joint. And if you have lockjaw, right, you have TMJ. So TMJ, that's where those are coming from. And all of these reinforcing ligaments helping stabilize this joint. The temporomandibular joint is a modified hinge joint, obviously, because it had those movements of elevation and depression, but you can also, and protraction and retraction, but you can also move it side to side. So, I don't know, I can't move it in a circle. I'm obviously trying. So it's known as a modified hinge. Because there's other movements other than just like the flexion extension that you can do. So looking in this cavity, I think about this more so with my younger son who had braces, and he had braces because he had an overbite, and the appliance that he had was called a Herbst appliance, and it locked these two teeth together and slowly re-brought his mandible up more. So it was really working with the muscle memory and this joint more so than shifting teeth. And then he had to shift teeth around too, because they had to shift around this way or that way. But that's all I have to say. I never really even talk about this. Okay, the ball and socket. So the shoulder joint is probably the most freely moving joint in the body. So this is a ball and socket joint, and it's most freely moving. It has a very shallow capsule. I'm just trying to come from, none of this has it. So it has a very shallow capsule, shallow articular capsule. It has the most range of movement. Most range of movement, and it has, it's a shallow joint. So I want to talk about that, but also most of the joint stability comes from the rotator muscles and their tendons that encircle a joint, but more so coming from the back. So if we're looking at this, right here is the scapula. All right, so this is the back. Oh, no, it's not. This is the front because this is the anterior view where you can't see it. So this is the scapula, this is the humerus, and then here in the front here is the clavicle, okay? And these bones just come together and the humerus just kind of hangs out in there. I have a lot of bursa to reduce friction and a whole lot of tendon sheaths in there as well. So it's a very shallow cavity. This is glenoid cavity. I'm just curious. Let's see. Does it talk about anything in the front versus the back? Nope. Okay. And just keep going deeper and deeper and deeper. But most of the reinforcement is across the back. So when a shoulder dislocates, let's go back to this picture here. When a shoulder dislocates, meaning the humerus comes out, it goes down and to the front. So it kind of pops out of this little coracoid, this process on the scapula. So it pops out, it goes down into the front because most of the reinforcement's in the back. So the front is not as well reinforced. So a shoulder dislocation, for those of you that have had it, I guess some of you have wacky dislocations, but typical dislocation is to the front and down. I had a funny story where I thought my son had his shoulder dislocated, but I didn't. I'm sure you guys have funny little stories as well. So the shoulder sacrifices stability for range of motion. We didn't do it personally, we just evolved in order to have awesome moving arms. Okay, so the elbow is pretty deep, deep joint, because we saw that that notch in the ulna where the humerus locks in. You can't really see it here, but you had the humerus locking into the ulna, that notch, that trochlear notch, and then you have this process of the Okernon process of it permitting, nothing else about it, permits flexion and extension. Okay, so here's the hip, and the hip bone connected to the so what you can't see in here is if this is my pelvis, and then I've got the head of the femur in that socket, the acetabulum. I have tons and tons of ligaments, tons and tons of muscles and tendons. It's a super deep socket, right? It's a deep socket, tons of reinforcing ligaments and tendons. And so here's where it shows you that it goes into that acetabulum. And then we come to the knee. The knee is with the tibia, fibula, meeting the femur. It's not a well-formed joint. It's a weak capsule with a lot of tendons and ligaments. So the knee, you guys all know about this. So with the knee, I have these collateral ligaments on the side, medial on the middle, lateral collaterals on the side. I have this cartilage helping form a socket between the femur and the tibia. That's known as the meniscus. So I have the medial, I have the lateral meniscus, and then even in the middle, I have these ligaments that form X's. Those are called cruciate ligaments. I have one in the front is the anterior ACL. The one in the back would be the posterior cruciate ligament, the PCL. You guys usually blow out your ACL. You probably blow out some of these collateral ligaments. It's just crazy, right? Let's see, what do we have here? Anything else that we want to talk about? So you have your femur, you have your tibia, you have your patella, you have all of these tendons coming in across the knee, inserting into the tibia. You have them going behind the knee, inserting into the tibia. From the back of the tibia, inserting into the femur. I mean, it's just kind of crazy with everything. Some people, sometimes they go in for the laparoscopic surgery because they've torn their meniscus and it's frayed. So that would be where they would go and shave some of the meniscus off, who knows what side. But that's what that is. It's shelves of cartilage. Oh, what else do we have? Look at this. This is just a crazy hot mess of tendons and ligaments. And when people get knee replacement surgery, that scares the crap out of me. Okay, so those are some of the joints. And now let's look at some of the joint problems. So as we age, where articular cartilage wears thin. Our ligament length and flexibility, they tighten up. So it's all about keeping them loose. And we have a decreased production of synovial fluid for shock absorption. So here's a hip replacement where they will, you guys that came to lab saw one, right? This is all that artificial hip replacement. This guy here, titanium, rebuilding this whole socket of the acetabulum and the head of the femur, because it just disintegrates over time and gets very painful. So yeah, look, this picture here is telling you that they remove all of this, of those two bones. All right, with the knee, oof. So with the knee, they shave all this bone down, they shave this bone down, and they put in a rebuilt tibia top, kind of like another meniscus, and then the femoral rebuild as well. How crazy is that? That's a knee. That blows me away, right? Because people seem to be getting knee replacements and hip replacements. Hip replacements, I think, are a lot quicker to bounce back from because they're not as complex a joint. So let's look at some of these disorders. Arthritis. There's a lot of different forms of arthritis. 3 that we're going to be talking about is osteoarthritis, rheumatoid arthritis, and gouty arthritis, okay? I'm even asking you guys, oh, look, I was able to move it. Huh, can I move it down? No, all right. All right, it's irreversible. Oops. Oh, this is about osteo, yeah. Well, let's go into the 3. So osteoarthritis is the most common one, and this is the wear and tear arthritis. This is, look, by age 85, half of Americans have osteoarthritis, mostly women, and it's when the articular cartilage breaks down. And so in those joints that are pretty overworked, like the hands, and then you get bone rubbing on bone. So the bone ends thicken and enlarge, restrict movement. There's nothing you can do, right? So this is the knobby knuckles that I am starting to get as well, in the metacarpal phalange, in the interphalange, right? Can't take your rings off. That's osteoarthritis. Ooh. Normal wear and tear arthritis. How do you prevent it? I don't know. Don't use your hands. Rheumatoid arthritis is an autoimmune disorder where your body attacks its joints. Oh, look, usually arises between 40 and 50. Maybe I've just dodged that bullet. Affects women 3 times more often than men. And what happens is you get inflammation in your joints, and these blood cells release all these chemicals to just sound the alarm of it's a problem when it's really not. You're attacking your own body, and that destroys the tissues, and the fluids collect, and then they solidify, and that forms this pannus, and the pannus breaks down the cartilage. I get scar tissue, and I get fused joints. What's the treatment? Just to slow it down, nothing else. And this is where you get really disfigured hands because of all of this inflammation that has just attacked and solidified. My grandmother had rheumatoid arthritis, so pretty painful, very disfiguring autoimmune disorder. Gouty arthritis is where I get uric acid crystals forming in joints and inflammation. Oh, good. Well, this one's more common in men. There you go, guys. Typically in the toes. If it's not treated, the bone ends will fuse and you will no longer be able to wiggle your toe, have a joint to move. Here's your treatment. Drugs, water, and avoidance of alcohol. Is that going to be possible? But here is some gouty arthritis in the finger, in the toe with those, I want to say uric acid. Oh yeah, uric acid crystals. So dehydration helps flush urea out of the body before it sticks around and can turn into these uric acid crystals. Lyme disease. We're from upstate New York, so we're pretty familiar with Lyme disease. Right here is my little deer tick, as a juvenile and an adult. It only feeds once per life cycle, so you have the nymph, and the nymph, I mean, you can't even see the nymph. It's like a freckle. And you know, what happens is it feeds once in the mice population, gets the bacteria, Borrelia burgdorferi. Oh, I don't have that specified. And then when it goes through its next life cycle and feeds on a person, then it transmits it from its salivary glands into your body. So you get this beautiful rash, bullseye rash. Maybe you don't get it. Right? It just looks like flu-like symptoms. Ooh. You just think you have a cold, but you know, it can live for a long time, hide out in your nervous system, and look like a neuromuscular disorder over time. And really it's just Lyme disease and can be cured with an antibiotic. So I think those are kind of interesting. I'm not going to read you about sprains and dislocations and bursitis and tendinitis. What's the difference? Nothing really, because that's all I got. So this lecture gave you some disorders. Maybe loved ones have them. Maybe you have them. I mean, I'm starting to get the osteoarthritis. It's coming. Something to look forward to. But really, we're just kind of looking at the different joints. There's just nothing. I don't ask you about those different joints on the exam, so don't get too crazy with those diagrams. They're just to appreciate how complicated your body is, and this is just one tiny little aspect of how complicated your body is. So take a minute and appreciate it and say thank you for working for me. Anyway, that's all I got. Good luck on your next exam. If you've used this and you've gotten some information, fantastic. If not, okay. I'm still going to record them. I will see you on the next one. Bye for now.